Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it.
There are a few mentors that you have in training that really push you, that force you to become better, both technically and non-technically. Dr. Janice Pasieka is an endocrine surgeon at the University of Calgary and has mentored many general surgery residents and fellows. In this episode, we have a wide-ranging discussion with Dr. Pasieka on issues ranging from gender equity to surgical education and training to Dr. Pasieka's rules on conferences.
Dr. Pasieka, thank you so much for joining us on Cold Steel today. We really value your time and your contributions to the podcast, and it really means a lot to both of us personally. Dr. Pasieka, we wanted to start off by finding a little bit more about where you grew up. And I was thinking back to this as now your former trainee. I realized I have never actually gotten the chance to sit down with you and ask you about where you grew up and how you ended up in medicine and in surgery in particular. So I was hoping you could share that with the listeners on the podcast.
Well, thanks very much, Amir and Chad, for inviting me and thinking that I would be a great addition to the wonderful people that you've had on your podcasts to date. So I actually was born in Sudbury in Northern Ontario and grew up in suburbia Toronto. And, you know, my family there, my dad was a mining engineer, my mother was a homemaker, and there was nobody in any of my family that were in medicine. So you can imagine when I just announced at dinner one day that I decided I wanted to go into medicine in grade 8, that they didn't quite know what to do with this girl. So I don't really know what it was that I focused on medicine. I think it was my love of the science and just a need to care for people, and then I set my sights on that and basically went to university. I went to the University of Western Ontario and decided that I was work hard to try to get into medical school, and I got in after my second year, so I never completed a degree before I started medicine. And it was, in some ways, to me, I see it must have been a calling, because I never looked back, and I couldn't today imagine doing anything else as a career or a profession. It's just such an honor and a privilege to be able to care for patients.
It's interesting that you say that, Dr. Pasieka, because we recently had Dr. Grace Rizicki on the podcast, and she had a very similar story that she just was in her biology class and just suddenly knew that she wanted to be a physician, and like you said, very similar words. Like, she just felt this calling, and I'm fascinated by this moment in people's lives where they just have this clarity of vision. Was there a moment where you sort of knew that this was going to happen, or was there an experience that made you feel that this was your calling, or did you just sort of gradually feel like this is what you wanted to do?
Yeah, I wish I could say that there was this aha moment. And when you interview the medical students and the PGY ones, when they sort of are applying, they give you these incredible stories of courage and things that happened in their life that set them on a thing for medicine. And to be honest, I can't think of an aha moment. I just remember sitting at the dinner table and announcing that that's what I was going to do. And it wasn't anything that I was being exposed to.
Dr. Pasieka, you have gone on to become one of the preeminent leaders in endocrine surgery, certainly in Canada for sure, if not in North America. What attracted you to surgery in general, and then in particular endocrine surgery? I remember what you said about colorectal surgery being an operation along the dotted lines. But so how is endocrine surgery different than that? And what made you want to do endocrine surgery?
Yeah. Well, there was an aha moment for going into surgery. I mean, once I got into medicine, I loved everything about it. And between my first and second year, there was an advertisement for a medical student to go up to Fort Frances, which is north of Lake Superior, to work as a medical student in their clinics up there. And I'm sure that the whole plan was to try to entice medical students coming up to rural communities to go into to help entice them to go into family medicine. Fort Frances is also close to Quetico National Park, which is just one of the best places to go canoeing if you're a canoeist. And so I immediately applied and got the job. So I went up there, and the mornings I spent with a surgeon called Jazz Spencer, and his wife was the GP anesthetist, and he did surgical lists in the morning, and then in the afternoon I was to go to the family medicine clinic. And it became very clear as soon as I was in the operating room that this is where I wanted to be. And it was hard to get me to go to the afternoon family medicine clinic. So that was the moment I decided on surgery. Endocrine surgery came around from the point of view of my love for physiology and my love for endocrine and endocrinopathies just fascinated me. And while doing general surgery at the time, I found it interesting and odd that we would do resections on Crohn's disease and ulcerative colitis. And as surgeons, we would make the decision as to what to take out and what to do and how to anastomose and all of those things. The gastroenterologists helped us with the diagnosis, but they didn't dictate the surgery. And yet endocrine surgery, when I was training, it was the endocrinologists that were dictating, just take out half the thyroid. We want you to take out this adrenal gland. And there wasn't a lot of thought as, the workup and that. And I really got into the workup and said, this is what I want to do. And at that time in Canada, at least, and certainly in Calgary, there really wasn't endocrine surgeons. So that story was, almost the same way I announced to my parents. I just decided that's what I wanted to do. And there was a senior surgeon here named Hugh Galley, who was just a delightful gentleman. And when I told him that that's what I wanted to do, he recalled reading the presidential address of Ed Ployan for the American Association of Endocrine Surgery on training endocrine surgeons for the future. And that address just happened to be a couple of months before I talked to Hugh. And he said, I think I'm going to give you something. And he gave me that journal. And I still have it. And basically gave me the advice that that's what you want to do. These are the people you got to go find. And that's what I did.
It's so amazing how so many of us, I think, have that epiphany moment as soon as you walk into an operating room. I think, and we see it sort of every day, right? We either see someone love it or somebody who just can't wait to get out of there. They're counting the seconds. There's no doubt. Dr. Pasieka, you and I have had a lot of conversations over many years about the importance or the role and the variable role, to be honest, of surgical conferences. And sometimes we talk about meetings in the context of their content. Sometimes we talk about the administrative or committee point of view. But really, certainly, the social aspect of things is something that you taught me a lot about, the importance of that. I was wondering if you could share with our listeners some of the framework or the rules that you look at with regard to conferences, because I think they're particularly relevant. They're easy to forget if you're trying to move up in these societies or give a whole bunch of talks. And the second question really I have for you is, this all seems to be changing in the here and now so very much. And you and I had also talked a little bit about the age of COVID and the shift of video conferencing. What do you think that means going forward, and how do you think that'll change what has been a very traditional model for many decades?
Yeah, that's a good question. So I'll answer the first on my, for those that haven't heard my spiel on surgical conferences. And, there's different philosophies that mentors will tell junior attendings and attendings on what to do about a conference, of joining different societies. And mine was that I think what you need to do is define your peer group, the group that you identify most with. So for me, it was the endocrine surgeons, and it was both at the North American, so the American Association, but also on an international level. So those were meetings that you wanted to present your work. You wanted to, illustrate that you were advancing the science of this subspecialty or specialty. And you use those meetings also to find collaborators. So it's your peer group that you would focus on. Other meetings you may have to, or you may go to, are ones in which are politically very important for you to go to be supportive, such as the Surgical Forum, such as the American College, and platforms like that. I think meetings and societies, the biggest thing you get out of them, beyond demonstrating to your peer group, is the networking and being able to meet like-minded people, but also the true giants and the leaders, and then evolving and working up in the organization, if that's what you like to do, to become part of and forming that organization. And the third thing that you get out of it is this incredible group of friends that are all over the world that you start to develop relationships with. And then the meetings that I like to go to, and why I probably did a lot of international meetings, was you visit very interesting and different places. You get to experience different cultures. And I think what Chad's alluding to is my rule of every conference that I go to. I have to attend the conference. I'm not going there just to sign up on the first day. So I attend the conference, but at some point I have to run or walk the city. I have to visit a museum or an art gallery. I have to visit a bookstore and take on some sort of social event. And I've been very dogmatic about that. And I even go a day early or stay a day later to make sure that I do all of those things. And it's allowed me to see parts of the world and see things that I never would have experienced. I find it would be sad to just fly in, go to the meeting, and then fly out and realize that there was a Van Gogh exhibit at the museum, and you'll never get an opportunity to see it again. So then you go COVID, and then they want to do this all on video. Well, I'm not sure how that's going to work, because all of those things that I enjoy about being a member of an organization and going to conferences, the networking, the friends, the relationship, the culture, and visiting places, is not going to happen the same way over the video. So I don't know. It's going to be interesting.
Yeah, it really is. I mean, there's so many different factors at play. I think, it's interesting to see the virtual meetings, conferences that have already happened. There's certainly a widespread, and I'm sure you've heard it too, description of real fatigue trying to sit and watch your computer on Zoom or whatever platform the individual conference is using for more than a couple hours at a time. I also wonder a little bit how the millennial outlook on the trainee side. My anecdotal observation for a few years has been there's somewhat of a less commitment to this traditional model of flying everywhere and spending money and taking time off work. So I do wonder, how all of these factors will converge and what it'll look like at the other end.
Yeah, I think you're right, Chad. I think, you can look at the upside that it is going to be less travel, and any travel, to a conference is time away from family, friends, and also your office. So it is stressful. So it may increase the attendance and the CME piece of it. But, the personal connection and, I remember so distinctly, my mentor, Norm Thompson, bringing me up and introducing me to Orlo Clark or John Hereditary, and just sort of, they shook my hand. And then the next time they saw me, they called me by my first name. It was a thrill. It was a thrill.
Yeah, exactly.
You're not going to get that on a Zoom, I don't think, but, it is our new reality, and we're going to have to somewhat embrace it. But I just don't know what the replacement for the other things that I mentioned are going to be. I don't know what that is.
Dr. Pasieka, one of the things that you've already alluded to is the fact that you like to actually go to international events, and you've been active in national and international organizations, and have gone all over the world trying to help educate. In particular, you've done a number of workshops and educational sessions in China. What has that experience been like? And what how has that enriched your practice? And what has that made you learn about endocrine surgery as a whole?
You mean China in particular, or just the?
Well, I feel like I particularly remember you when I was on service, you going to China and teaching these huge seminars to all these people. Yeah. About how to do, whatever the topic was in endocrine surgery, whether it was ultrasound or the actual technical aspects of doing the surgery. And I remember listening to that and just admiring kind of the challenges that posed of going to a completely different country where the languages are different, but yet you were super excited about that, and clearly you were passionate about that. And so I chose China, but obviously you've done that in many venues. And so I was just curious what that experience has been like for you.
Yeah, it's been a real enriching experience for me on a personal as well as a professional level. It really is. I'm fascinated by the different cultures, and if you take the time to sort of observe and try to learn a little bit about the diversity in this entire world and how these different cultures all come together. We're all doing the same thing, taking care of patients in our area or whatever. I found that to be quite fascinating. I also then felt, and recognized it was important to get out of my comfort zone every so often to really sort of, help me grow as an individual and to sort of experience life in a different way and see how other people who seem incredibly happy with very little, as far as physical possessions and that, and yet they seemed happier than most of the people that I knew back in North America, and just trying to understand that and understand what, happiness is from your heart and your soul. I also found that when I traveled internationally that in a lot of these countries, they were actually doing cutting edge stuff that hadn't quite made it to North America. They were doing it, and I was bringing back knowledge that hadn't made mainstream North America academic medicine. I mean, a good example is, taking the thyroid out through the mouth with no incisions on the neck. I mean, this was, developed in Malaysia, and, within a couple of months, they had done 50 cases and then were presenting it. And now that's considered one of the techniques, but it was really cool to sort of see it at the onset, because of the different cultures, the different ways that they can practice medicine. They were able to do something like that without having to go through the rigors of what we do here in North America, new technology and new things. So it's been really quite fun and enriching.
Yeah, it's amazing how these international experiences by yourself and ourselves and just all of us in general, including some of our guests, really impact how we practice when we come back, and certainly mentally and sometimes physically as well. It's quite neat. Dr. Pasieka, you're certainly not defined by this, of course, and you certainly don't brag about it. But I'm going to brag a little bit for you, for our listeners, and I'm curious what your thoughts coming out of my comments will be in regard to gender equality in particular. And for those of us that know you, I mean, you were, I believe, certainly the first Canadian, and I think it was the second woman to be president of the American Association of the Endocrine Surgeons about 10 years ago. You were also the section head of general surgery in Calgary, which, just based on structure, I would venture, and you can correct me if I'm wrong, is certainly going to be the largest general surgery cohesive group in the country. You did a lot of that, not only as a woman, but also relatively early, so to speak, in the arc of your career. I'm curious how not only those accomplishments, but maybe more importantly, how gender equality has really come to the forefront so strongly in the past 1 to 3 years. How you view that, how you apply that to surgery. One of my other comments, I guess, would be that I noticed this year, looking at our University of Calgary poster, that we finally have an equal number of women trainees to men trainees, and I think that's just superb. But how do you view the way the world is working right now and the discussion that surrounds that concept?
Oh, wow. That's that's a big topic and interesting one, because gender equality. Obviously, I was one of the visible minorities when I was starting out my career. But you can look around at the structure of all the residency programs and departments. There's a lot of other visible minorities that aren't necessarily being represented at the leadership level. So I think the gender equality is one aspect of a conversation that's worth discussing. But when I look at it, I would say it's all diversity. It's all underrepresented visible minorities that we should be putting in the same kind of grouping in some ways. From a purely gender perspective, I don't know how to say this, but I never thought that being a woman was going to take away my ability to achieve my goals. I knew I was standing, on the shoulders of the pioneers that really did break that barrier of being women in surgery. The Frances Conleys, Robin McLeod, the Pat Newmans, and people that really, started that movement. So then when I applied as a resident to get into a residency, it wasn't such a foreign concept. So I think they accepted me on my merit. But, the difference at that time was that I wasn't, not everybody in the division really thought I should be there, but they could tell me to my face they didn't think I should be there, that they didn't believe women should be in surgery, that I was taking up a spot, and I didn't have any repercussions, and they didn't see it as being so politically incorrect and being hauled up into somebody's office saying you can't say those things. They could voice their opinions in public, and so I at least knew what the landscape was. And I knew I wasn't equally accepted across all boards. Then I think when I was sort of, mid-career, I recognized that it's politically incorrect to truly state your bias, and so it went underground, and yet it was still very much there. And that's when it scared me more, because then you didn't know who was on your side, who wasn't.
Right.
And I think that you could look at this, what's happening right now with Black Lives Matter. And, if you read about the 60s and the civil rights, I grew up thinking, okay, well, they've sorted that one out, that, all lives matter and there isn't any racial discrimination. And yet, all of a sudden, it clearly is still there. There's this unconscious bias that we all have for various reasons. And because it's not being talked about and openly spoken about, it's a little more frightening to me. So maybe having a little bit more of a dialogue and people thinking about it and bringing it back to the forefront will at least help things. But Chad, I don't know what the question was. You got me on that.
No, I think that's that's clearly very, very well said. I think it's about time, and I think you're right. I mean, all this discussion and all this interaction, whether it's been professional or unprofessional, lumped together, I think is probably helpful, because it does put the issue of equality across the board on the forefront of everyone's mind. And I think all of us should be appreciative of that.
Yeah. And what I would like to see is just more of an embracing of diversity. I mean, that's just it. We don't want a bunch of people to then all form into the same model of, what the Department of Surgery has always been. What we want is a whole bunch of diversity around the table that are doing it very differently because of their culture, their upbringing, their race, their gender, their whatever. And I think that's what we need to be more accepting of, that it's okay to accept somebody's going to do something completely, or not completely, but do it a little bit differently because they bring diversity to the table, but be accepting of that. And
absolutely. And exactly, you and I have talked about this before, and I've talked about it both on the podcast as well as with other guests privately. And, specifically, there's no question that strength comes from diversity, and we can be social about it, or we can actually be mathematical about it. And Scott Page's work has shown that now in 2 separate books, that there's an actual finite descriptive formula, mathematical formula for productivity and efficiency out of diversity that is improved. And it's remarkable. It's having seen him speak one time as sort of the presidential speaker at HPBA, I want to say 4 or 5 years ago, it was the most remarkable talk I've ever seen, and it really set off lights, I think, across 1,000 HPB surgeons at that meeting. There's no question that diversity should always win, biologically and psychologically.
Yeah.
Dr. Pasieka, I wanted to, I wanted to just mention this story because I think it's one of the neat stories that you've told me about what it's been like just just fundamentally what it's sometimes like to be a female trainee that perhaps we just don't understand if you're not a female trainee. You tell the story about coming back and starting as a staff surgeon at the Foothills and not having any scrubs that actually fit you. And it wasn't until Dr. Kwan, Malin Kwan, who's one of the breast surgeons in Calgary, until she came in and kind of insisted that they bring scrub sizes that are small, that were small and that fit appropriately, that you actually got scrubs that fit you, that weren't hanging off you. And I think this story is important because on the one hand, you're saying that you never felt like that you were discriminated against, or at least if you were discriminated, it was kind of open and to your face. But underneath all of this, you did have to overcome many of these kind of unseen, subtle barriers that male trainees just didn't have to face. And I'm curious what you tell female trainees. I know you've been active in having a group with the female surgical residents, the female general surgery residents in Calgary. And I'm curious what you tell them and what advice you have for them.
Yeah, I think that, it is important that they recognize that there's going to be things that are going to be different. And one of the ones that I think all female surgeons will talk about is the relationship with the nurses when, you're a junior resident and you show up on the ward, and that can, women don't play well together until they know each other well enough. And so it's important. And I tell them to, you're not there to pick a fight. You're there doing the same job. But what you have to do is to prove to them that you are capable of this. And don't worry how they treat your male counterparts. Worry about your own integrity and be true to yourself. It doesn't mean you have to then start taking on male qualities to be able to get the job done. Do it in your way. But if you show them that you can take care of patients, that you will respond to their needs and treat them as a part of the team, it may just take a little bit while, but then they'll respect you, and then they will be your allies. So, I think there's a lot of sort of angst initially, just trying to make sure that people recognize, no, I'm not the nurse, I'm the doctor, or I'm not the housekeeping staff, and because it's just what happens initially, even patients, but not to react to it, but to embrace it and prove that you're just as capable as the next.
I think, that demonstrates, again, how much you care about resident education. I think any of your trainees, current and former, will talk about having trained under you and the things that they've learned. I know I certainly have learned a ton from coming on your service. I mean, I came on, I think at the beginning of my 5th year, the end of my 4th year onto your service, and I thought I knew how to do things like tie a knot around an instrument, and spending a few weeks with you was enough to just realize that, like, your dedication to the basics and really getting those things right, not only just technically but also conceptually. Like I still remember the little chalk talks you would give on the drapes while we were waiting for the pathologists to come back and tell us if we had the parathyroid. I'm curious about what you think. I think I understand what makes you a great teacher, but what do you think are the characteristics of great teachers? And in particular, I'm very curious as what your approach is to the trainee that you don't think is interested, and how do you approach that situation?
Oh, well, okay. Well, first of all, Amir, I don't need a pathologist to tell me that I have the parathyroid adenoma. I just want to make sure that gets on the podcast.
I would never suggest that.
I was
never
waiting for that.
So I'm sorry, but Amir, okay. Well, first of all, I a great teacher. I don't know if I'm a great teacher. I do my best to teach, and I do try. And I've sort of, there was a time that I wasn't such a great teacher, and I was not connecting with the trainees, and it took me to sort of step back, and I took on a coach, Lara Cook, who is an educator here, and she's a neurologist. Took my challenge on, me as a challenge, and really, because I was baffled by why I wasn't being perceived as teaching. All I was trying to do was to teach, and it wasn't coming off correctly. And I know I'm intense. And so she really, as a coach and having that educational background, taught me or showed me how I was teaching and what I was teaching. I was teaching at a different level than this new generation of medical students were used to. And that's what sort of floored them. I wasn't asking for didactic regurgitation from a textbook. I was asking questions, as you know, that are a little off tangent, outside the box, but it gave me the ability to see where you were thinking. And once I started to understand a little bit about what my style was, I wasn't about to change that, but I recognized that I had to then spend more time trying to understand when I ask a question, hear what the answer is coming back to me, and then trying to figure out how I can work them through my algorithm or the way that they need to start thinking about this disease or whatever it is, by enticing different questions, because they would have the knowledge, they just haven't put it together in a box or on an algorithm. And that's been, that's been a great learning process, and it really gets my brain thinking. So when I ask you a question and I get some sort of answer, I have to figure out, well, that's not even close, but where is that coming from, and sort of start working from there. And so I think I've improved. I think I'm a better teacher from that perspective, and I think I challenge people. And so how do I reach the trainee that's not interested in learning? I think I don't. If they are too not interested or can't answer a question and say, well, I just don't know, and they give up, then I can't delve and use my brain or knowledge to try to figure out how to get them back on track and try to show them that they actually do know. They just haven't put the two pieces, A and B and C, together. And so if they give up, I give up. And yeah, I'll be honest, I know that that's what I do.
I just have to comment that it's amazing that you took it so seriously about resident education, that you would actually get a coach to help you get better. And I think that just shows just the level of dedication that you had to the craft, but also the insight that you had that you just felt like things weren't connecting the way that you wanted to. And that's just amazing to me. I think one of the challenges that you in particular face when you have general surgery trainees is that, increasingly there are fewer and fewer general surgeons who are doing thyroid and parathyroid in particular. And some of us may never do that probably ever again in their career, which is kind of sad for me to think about. But I'm curious how you navigate that dilemma of having someone that you want to get a lot out of the rotation and a lot out of the experience, but may never actually do that operation again, and probably doesn't have much experience doing it. How do you walk that line, especially with the third factor of the context in which we live in, which is that trainees just aren't getting the volume that they used to?
Yeah. So you're absolutely right. So I think a lot of things in general surgery are becoming so subspecialized that there are going to be operations that people will go into a specialty that they won't do, particularly if they subspecialize in a remote, completely different area. But that doesn't mean that the techniques and how to handle the tissues in the neck aren't going to translate into being able to do that in another part of the abdomen or with breast surgery and all of those things. So I see it as there are trainees that I'm teaching the surgical techniques to be able to apply to wherever they are. I think that it's your other part of the question was the how do we optimize this time in this environment. This is a real challenge, because what's happening is more and more fellowships and more people coming and wanting to focus and do, let's say, endocrine surgery. And obviously you want to get them to master that part of it, and that could be at the detriment of the resident. So you try to involve them in different parts of the cases and get eventually the fellows to also be part of the teaching. But when they're getting into the OR less and less, and I guess as surgeons, and Chad can attest to this, we're under this incredible pressure of being more and more efficient. I see it's going to get even harder and harder. And I don't have a good answer.
Yeah, I'm not sure there is a good answer yet. I think you're right. Maybe in getting close to closing, Dr. Pasieka, I wanted to touch on a couple of fun things. The first is you and I have talked about the HBO series called Chernobyl that outlines those events a couple of times, and certainly the impact or the interaction with ionizing radiation, medicine, and surgery and diagnostic tests is strong, and I think it's an interest of both yours and mine. And although I wouldn't say when I think of radiation, I think of you, but certainly when I think of radiation, I do think of the thyroid. And I was wondering if you could just talk a little bit about, almost from a didactic point of view, about radiation and thyroid cancer and where that all sits.
Yeah, I mean, radiation has been shown to be one of the risk factors for developing thyroid cancer, and it's just a fascinating story on how it was sort of first discovered, and it was a group of epidemiologists at the University of Chicago that sort of put the piece together when they started seeing in the cancer center a high number of patients that were in their 20s and 30s that had thyroid cancer, this sort of big blip. And they noticed that they were all upper middle class white Americans and not the major population of Chicago, which was African American. And they then started to try to figure out what the difference was. And what the difference was access to healthcare. And these young adults, when they were children, their parents had the ability to get them the best healthcare at that time. And so in the 50s, they were getting their thymuses radiated. They were getting radiation, low-dose radiation for acne, for mastoiditis. And we created this problem, but in a group that were thinking they were getting the best healthcare. And that then really sort of allowed us to then understand that, ionized radiation was a risk factor to thyroid cancer. And then the next sort of many other pieces, including the atomic bomb but the other and the Marshall Islands and the nuclear testing have sort of reiterated that. But it was the Chernobyl incident that was a fascinating story as well, in that it happened in 1986, and they started reporting that they had this high incidence of childhood cancer only 3 years out, and everybody in the Western worlds were saying, well, that's not from radiation because it's got a 20-year lag period. 3 years, it can't be from the radiation. And these guys persisted and kept showing it. And sure enough, that type of radiation, because it was short-acting isotopes on young kids, it was creating thyroid cancer at a much rapid growth. So it is fascinating. And I think the story on the number of CT scans and what we do, maybe 20 years from now, we will rethink all of that as well, Chad.
Yeah, it's so interesting how the technology piece also plays into it now. There's a significant biologic rationale, of course, as you do know, that perhaps that model, the Chernobyl model, doesn't really reflect what we do with CT scans, independent of their decreasing radiation dose. Sort of one big blast versus multiple lower dose exposures may not be equivalent from a DNA repair point of view, and so on. So it's certainly really quite fascinating. The second last thing we wanted to ask you is about your love for collegiate basketball. I think most of us that know you know it's a huge passion. So
March Madness.
Yeah, we're exactly. We're in particular curious as to how that came about, why Big Blue, and I'm really interested to know what you think about essentially the legal world in the U.S. now driving more pay for those collegiate athletes who, as you know. From a gender equality point of view is unfortunate, but really it's these large collegiate football programs and men's basketball programs that really drive the financials for the entire athletic program in most universities that are of the right size.
Yeah. So, this is going to be 2 years in a row. I'm going through withdrawal. There will be no tournament this year as well.
Yeah.
That's 2 March Madnesses that it's going to be tough. Since I was 10 years old, I've been an NCAA basketball fan, and initially Marquette, because of Al McGuire was a great coach, and I love the way he coached it. And I played basketball in high school and university, and then I was a Blue Devils fan because of Coach K. But that stopped on the first day I was in the operating room with Norm Thompson, and we were operating across the table and. Just starting to get to know each other. And he was I had arrived at Michigan, and he said, oh yes, you're a basketball player and you like basketball. And I said, oh yeah. And I'm a Blue Devils fan. And the room just stopped. And he put down the cell phone and he looked at me and he says, that either changes today or don't show up tomorrow.
Wow.
And with a twinkle in his eye, because he was just a true gentleman. But the next day, go Blue, absolutely, and go Blue ever since.
Well, you're as usual. You're a much better person than I, because having grown up in Edmonton and now living in Calgary for the better part of close to 20 years now, I still cannot convert to a Flames fan. I am curious what your thoughts are about the increased pay for NCAA athletes.
An NCAA, athlete, you're there to go to university and to be a varsity athlete and to do both well. And that's why, if I'm looking at a resume of a resident fellow or whatever, if they were a varsity athlete, right away they're up on my list, because I know they can multitask. I know they can juggle many things. They have discipline. They've obviously have followed 2 passions in their lives, and hopefully more, that type of thing. So I see NCAA, if you want to, make it your career, then try to play professionally. But if you're at university, I want you to go to university and get an education.
Yeah, it's true. It's such an interesting and complex topic. My dad was a dual athlete at the University of Minnesota. He was a quarterback and he also played hockey. And then he went on to a professional hockey career with the Boston Bruins for a little bit, as you know. And it's interesting to listen to him in the years that he was in that university. He didn't write a single exam and he didn't go to class because he didn't need to. His job was to play athletics. And then, of course, when the pro hockey career died relatively quickly because of injury, he had no education. He really had no way to make a real income. And my mother at that time was pregnant with me, and all of a sudden it was a bit of a crisis. And, to his credit, he went back to university. He became an accountant, and he did really well. But when he talks about the guys that he grew up with in that era doing those same sports, most of them did not have such a positive outcome at all. So, he certainly felt strongly with my brother and I that you had to go to school, and that was the goal. And there was no negotiation about it, whether you were playing university hockey or whether you weren't. So I completely agree with you.
Yeah, and I think from in the women's, there isn't a professional women's field hockey league that you're aspiring to. So most of the women sports are not there as a means of getting a scout to pick them up professionally in the same way. But obviously, as you say, the football and the basketball, that's big money there. And I don't like when I see good players leave early and to get, to go into profession, because then I go, well, you didn't get your degree.
This has been such a delightful conversation, and we're so glad that we could have you on the podcast. I've learned so many things about you, and it just makes me reappreciate your dedication to the field of surgery and to our dedication. So thank you from all of us. In closing,
my pleasure.
In closing, I wanted to just ask you if you could go back in time, and this is a question we've asked all of our guests. If you could go back in time and give yourself advice at the junior resident level, at the chief resident level, and at the tending surgeon level, what would those pieces of advice be?
So at a junior resident level, it would be, just keep your head down, work hard, and take care of your patients, and that will serve you well. As a chief resident, I probably would tell myself, lighten up with the medical students. Not everybody is as passionate about surgery or cares the way you do. So you don't have to ride them as hard as you did. And spend time just making sure that your junior resident is doing okay, because they'll make you look good if they can do their job. For an attending, I guess I would say, when you're starting out, follow your passion, your passion in medicine and in particularly surgery, but also follow your passions outside of medicine, and don't give up hobbies that you're passionate about and say, well, I'll get back to those at another time. Always keep them as part of your ability to to step away from medicine and be true to yourself. I would say, above all, take care of yourself, both and your family, and make sure that becomes a priority. And it can't be a priority maybe every day, but you got to keep working on that. And I think the one thing that I didn't do early in my career, but I'm certainly doing more and more as I quote mature, and that is I go out of my way to try to learn one thing every day from a patient, and I'm not talking always about some new diagnosis or something in medicine, but to spend the time and get to, find out a little bit about them and learn something new every day. And you'll go a long way.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.